All right, and we are recording. Are we ready to start letting participants in?
I think we're ready.
All right.
All right, folks are entering the Zoom conference. We are delighted to have you all with us. I'm Peg O'Connell, chair of the Care for Carolina Coalition. We are now at 67 members of this statewide coalition. It is my great pleasure to welcome all of you in Zoom land to this morning and afternoon session. And it is even my greater pleasure to thank Iredell Health Systems for serving as a co-host for this forum. And I'd like to turn it over to Miles Atkins, who is the mayor of Mooresville and the director of corporate affairs and government relations at Iredell Health Systems. So Miles, Mr. Mayor, would you like to say a word of welcome, and then we'll proceed?
Thank you, Peg. I certainly appreciate it on behalf of Iredell Health System, which is the only independent nonprofit healthcare system in Iredell County. It's our honor and pleasure to be a co-host with Care for Carolina. This is a very important issue to all of us, and we just appreciate being able to co-host this forum with you this morning. So thank you.
Thank you very much, Miles. So one of the stars of our show, who has done a wonderful job of pulling together the numbers that about the coverage gap in COVID. Jason Gray is a senior fellow for research and policy from the North Carolina Rural Center. Jason, tell us what's going on.
Good morning, everyone. It's a great pleasure to be with you. This has been a wonderful series of briefings we've done around the state, and it's particularly been great to meet the other presenters and those healthcare providers who are working in the front lines of seeing to the quality of life of both individuals and communities. So, I'm with the North Carolina Rural Center. So the Rural Center is chiefly around economic development, advancing the economic prospects for individuals and rural communities. So how is it that we got involved in this? We did so because we believe that there are huge economic implications to having quality healthcare and quality healthcare systems. Next slide, please. So what I'm going to talk about, and I'm going to take an economic framework on this, is to talk about the context of the coverage gap from a chronic, that is long-term perspective, and then an acute short-term perspective based on preliminary numbers that we're seeing of the COVID-19 pandemic's impact on communities and what it may mean for closing the coverage gap. Next slide. So I'm going to be, I've lucked out here in that I get to talk about numbers that other people have run. So the numbers I'm going to be sharing with you is from this report, the Economic and Employment Benefits of Expanding Medicaid in North Carolina. It was originally released about 4 years ago, and it was updated last summer. And it was done by the Millikan Institute School of Public Health at George Washington University. These are healthcare economists who did the report. And it was underwritten by the Cone Healthcare Foundation and the KP Reynolds Foundation. Next slide, please. So it's important to understand that the numbers I'm going to share with you. I tell people that astrophysicists studying a star 5 light years away can tell you its chemical composition down to the second or third decimal point. When we talk about economic numbers, particularly economic projection numbers, we can't have the same level of certainty. But we can get in the ballpark. We can get close, and I say that because I want you to understand that the numbers that have been used, numbers generated, used a commonly used economic impact modeling program called REMI for short, otherwise known as the Regional Economic Models Incorporated. It's one of 2 of the major software economic impact analysis software used in the country. And REMI examines the flow and the outputs in local and regional economies. You think economic multipliers. A company moves into a community, it creates jobs. Those employees get a salary, They spend that money in the community, which allows other people to get hired, who then are paid and spend money. So it's looking at the multiplier effects within a community. So REMI is used by a variety of North Carolina state government offices, the Congressional Budget Office, the White House Office of Economic Advisors, the Economic Development Partnerships in North Carolina. They're also using it. Every major recruitment project for a major industry in the state, chances are good somebody is using REMI to figure out the economic impact from that. So I spend time with this just for you to understand that these are fairly reliable and commonly used systems. We're not just making this stuff up. Okay, next slide. So to the quick, and those who know me know that I can talk at great length in exhaustion on this topic. So I'm going to try and keep my presentation concise here. So the economic impact of expanding Medicaid in the state. We took the county numbers and then we ran them by the county classification system the Rural Center uses. We consider 80 counties in the state rural, 14 that are either suburban or what we call regional city counties. For example, Buncombe, because Asheville tends to dominate the county, is a regional city county, as is Pitt County with Greenville, and then 6 core urban counties. I'm a rural guy, so I'm going to focus on the rural numbers, but you can see the numbers here. And from the update that the GW University folks did from 2019 through 2022, should Medicaid be expanded, we're looking in the rural county, some 11,000 jobs. Gross county economic impact of $1.9 billion. And local tax revenue of $33 million, which is pretty significant, particularly now, given the impact that the pandemic has had on fiscal conditions in localities. For our 40 most economically distressed counties, our tier 1 counties, that economic impact is around $1 billion. And there's hardly any program the state could advocate that would have that kind of impact in our most economically distressed counties. Next slide, please. Okay, so I just here have a representation of some of the counties in the region for this session, just to give you a little sense of what it looks like. So in Alexander County, an estimated 72 jobs, $7 million of economic impact, and local taxes of $194,000. That tells me there's not a huge medical facility presence in the county. Now compare that to Cabarrus, where there is such a presence. 547 jobs, $99 million of broad economic impact, and $2 million in local tax revenue. Davie County, more of a rural suburban county, 76 jobs, $13 million of impact, 471,000. Then Rowan, sort of again in the middle, 67 jobs, $74 million of economic impact, and $1 million in tax revenue over a year period. Next slide. So when you look at these by the economic development partnerships, and the region which we're discussing today is mainly in that let's see, which is in the Charlotte region, 7,197 jobs, 7,000 jobs up in the Triad. So the job growth in the region is fairly substantial compared to some other regions. Next slide. Gross county impact in the Charlotte region, $1.7 billion. Again, that's a reflection of the clustering of medical facilities in the region that we see in our large urban counties. See the same impact in the Triangle, $2.2 billion because of the medical research universities, Duke and UNC, and then the hospitals here in Wake County. But even in our more rural areas, say northeastern North Carolina, $233 million, up in the Northwest, $372 million. So the impact is pretty wide all across the state. Next slide. Again, when you look at tax revenue, bigger in our more concentrated urban areas, because that's where the medical professions are more concentrated. The jobs do spin off into other non-medical healthcare sector jobs, but chiefly it is in that healthcare sector. So economically, this is a big deal, and particularly so for rural counties because it helps our competitive advantage. Next slide. So I want to shift now to trying to get a handle of what does the pandemic mean for this. So we looked at January employment numbers and July employment numbers. When I did this, updated this slide recently, the August county data hadn't been released. I think it is released now, however. So the impact of the pandemic has been pretty substantial, as we all know. 94,000 fewer employed in our rural counties, 105,000 in the 14 regional cities, suburban counties, and 155,000 decline of 8% in our 6 suburban counties. So what's interesting to me as an economic geography nerd is that the impact of the pandemic in the state is reverse of what the Great Recession was in 2008 and 2009, which disproportionately hit rural communities, particularly manufacturing dependent rural communities. But this time around, it's our more urbanized areas that have been hurt worse, mainly because of the concentration there of retail, concentration of restaurants, and those were the sectors that got hit hardest first, and then it's trickled out elsewhere. So total of 354,000 fewer employed. It's a big hit. Now, these numbers are considerably improved over where we were in May. The question is now, are we going to continue that improvement, or are we beginning to stall out, which I'm beginning to see some signals that we are. Next slide, please. Okay, to look at this from an unemployment insurance perspective, and we've got the August numbers. We've got 226,000, almost 227,000 total continued unemployment insurance claims. 143,000 of them are COVID related. How they absolutely determine that, I'm not certain, but 63% of all the unemployment insurance claims are deemed to be related to the pandemic. Again, this is a big improvement over May and June. So next slide. So of those who have filed for unemployment that are continuing claims that are COVID related, 143,000. How many of these folks have lost their health insurance? That's the big question healthcare providers and policymakers are now asking. And the truth of the matter is it's hard to get a precise number. We really don't know. We'll have a much better picture in 6 months to a year. There's been a number of different policy groups and research groups that have tried to do back of the envelope estimates. The one I'm using here is from the Commonwealth Fund, estimates that 21% of newly employed are without coverage. Using the above estimate, that would be an additional 30,000 people who are in need of health insurance but don't have access to it. Is this a reasonable number? You know, it's a reasonable guess. It could be a little bit higher. I doubt it's lower, but it could be a little bit higher too. Next slide. So what I want to close on here is that closing the coverage gap has substantial economic benefits to communities. And particularly for rural places who are already struggling to keep their medical infrastructure in place and who require that infrastructure in order to be economically competitive. Closing the coverage gap is a huge economic deal. It matters for the economic health of the households who would have insurance coverage, but it matters just as much for those of us who have health insurance, because we cannot have competitive economies, competitive rural economies, if we don't have healthy health infrastructure systems. We've got to have good schools, we've got to have adequate housing, and we have to have those quality medical facilities. And a lot of rural communities in particular, their health facilities rely on Medicare and Medicaid payments. So it matters for everybody that we have an economically competitive state. And again, I could go on at some length on this, and hopefully I'll be able to answer some Q&A. Okay, in light of the pandemic disaster, closing the coverage gap would support a substantial number of citizens who find themselves without coverage. States that have expanded Medicaid are in a competitive advantage situation from where we are now, even with the federal CARES Act money that has come down. So again, my bottom line is that it matters not only for those people who we want to get coverage. It matters for all of us, and it matters for our communities. So with that, I'll hush and turn it over back to our moderator, and I look forward to joining you all for Q&A towards the end. Thank you so much.
Jason, thank you. You always do a very good job of making complex data easily understandable and also convey why it's important. So we really appreciate it. We also know that you have to dash for a few moments. So if Jason's screen suddenly goes away, he will be back because there's always lots of questions for him. And speaking of questions, so how we will proceed is we will hear from the rest of our presenters, and then we will open up the mics and the chat box for questions. So if you are thinking of questions as people are speaking and you'd like, and then we will open the mics. You can go to participants and it'll bring up a whole list, and then you have the ability to raise your hand. So there will be lots of time for conversation after the presentations. So now it is my pleasure to introduce you to Jeffrey Katz, who is a PA, a physician's assistant, and part of Iredell Family Care Center in Taylorsville, which just happens to be the hometown of our own Erica Palmer Smith. Jeffrey is not only a well thought of healthcare practitioner, he is also the former state and national president of the Physician Assistants Association. So Jeffrey, please tell us what you're seeing on the ground in your area as a healthcare provider.
Thank you very much, and also thank you for inviting me to be part of this distinguished panel. I do need to say that when I was asked to participate, I didn't know that Iredell was actually going to be hosting this. So I need to say that I don't represent the views of my employer, so I know I'll have a job tomorrow if I say something that kind of makes their eyebrows go up, nor any of the boards that I serve. So we all kind of want to look at how does underinsured patients, what happens to them? We all know that underinsured patients don't come in for screening because it costs too much. You know, to come in for a physical, how much does it cost for the lab work? How much does it cost for the office visit? How much does it cost for the follow-up? But we don't tend to see people for screenings. And then once they've been diagnosed, in order to kind of maintain them and kind of make sure that they don't develop problems along the way, we don't see them for follow-up either, just because of the expense of this. I thought it would be best to basically discuss how to do this and basically talk about patients. So these are real patients that I have. I've changed their names to protect the innocent, as they say, but they're folks who I kind of worry about and spend sleepless nights about because of their problems. The first one I'd like to talk about is Bob. Bob is a 43-year-old fellow. I see his wife and his children. He was diagnosed with diabetes 3 years ago. He was hospitalized because he was having nausea and vomiting. He was basically discharged from the hospital in 2.5 days. They never determined if he was a type 1 or type 2 diabetic because, oh, you're supposed to follow up with the endocrinologist. Well, number one, the endocrinologist wasn't going to see him because he didn't have money to put down for payment for that visit. So he never was diagnosed as a type 1 or type 2 diabetic. The way how he's been managing his diabetes is he buys insulin from Walmart and he takes 15 units of insulin twice a day. He has no idea what his blood sugars are. If we were typically following a diabetic, we'd follow him every 3 months to make sure that his hemoglobin A1C, which is a measure of how well controlled their diabetes is within acceptable range. I've kind of kept up with him through his wife, because every time I see her or her children, I ask how he's doing, and gosh, I'd really like to see him to kind of see where he's at. He went to the emergency room about 4 months ago because he was having severe abdominal pain. They worked him up. They found out that the reason was he had a hernia around mesh where he had a previous umbilical hernia surgery. And they said, oh, you need to go see the surgeon. He did manage to get enough money together to go to a surgeon. His hemoglobin A1C was 11.1. You know, what we like to see is 6.5 to 7. The surgeon said, I'm not going to operate on you until you can get your sugars under control. Well, how is he supposed to get his sugars under control? He doesn't come in because he can't afford the office visits. He works, but he can't afford the insurance for that. Problem. Second problem, dear lady who I see, who's basically about 50 years old. I've kind of seen her and her children for many years. She was married to an alcoholic, abusive husband who covered her with her insurance at the time. She has high blood pressure and she has cholesterol problems. She unfortunately smokes and she has some anxiety. I saw her about 5 months ago also. Actually, probably was a little bit more like 7 months ago, because it was right before COVID. And she came in and she was short of breath. And the problem was that when we did her pulse oximeter, it was 85%. That's kind of bad. Everybody knows now more about pulse oximetry because of COVID. So was able to get a chest x-ray. Oh, sorry, she actually finally divorced from her husband after my urging, because he was physically abusive to her. Took years for her to finally come to the realization that she needed to leave him. She wanted to stay around for the kids. The kids finally graduated high school. She divorced him. When she did, she was on his insurance. He dropped her from his insurance. She works cleaning houses, so she doesn't have an employer even that she could get insurance from. So she's uninsured. She came in 7 months ago. Her pulse oximetry was 85%. Got a chest x-ray, which was normal. And that's all what she would let me do, because she likes paying her bills. She didn't want us to do any further workup. Kind of scary. She really needs a chest CAT scan. She needs spirometry, probably needs some supplemental oxygen. Kind of refused for us to do that repeatedly. The only bright spot is that I put her on some medication, which was difficult also to do. Took a lot of time because we had to go through patient assistance programs and the like. And her oxygen saturation is up to 89% now. I'm not sure what's going to happen with her or Bob. Unfortunately, what I can almost guarantee is that they will not do well and that they'll ultimately be hospitalized and develop multiple comorbidities that are going to cost much more in the future. So then COVID came around. Well, COVID, we've been promised that you can get a free test for COVID if you need one. Everybody can get a free test. Well, that's great. The problem is that even though you can get a free test, what do you do about the money for medication? So if somebody needs an albuterol inhaler, that costs $40. If somebody needs a steroid inhaler, it's $300 for them. Who's going to be able to afford that kind of money? The other problem that COVID has brought, as we kind of heard before, is that many of the companies here in town have downscaled. They've either laid off or basically let go of their employees. So I have now many folks who are coming in saying, gosh, you need to do everything right now because my insurance is going to run out in 2 weeks. What are they going to do afterwards? COVID is expensive. If they can afford it, that's great. But many of my folks can't. So what happens to them? Here in Alexander County, we have no hospital. Our hospital closed down not once, but twice. It's been closed now for many, many years. There's no free clinic that I could send folks to. The nearest free clinic is 30 miles away. while some of the hospitals offer, and they call it charity care, many of my folks are proud people who work, and they don't want charity. They really want care. What do we do about that? And I don't have those answers, but if you guys do, I'd appreciate hearing. Thanks.
Thank you, Jeffrey. That was very compelling. And the fact that this is hitting people so hard in an area of our state that was robust in its manufacturing and for such a long time, it's an especially difficult thing for the people who find themselves in these difficult situations. But we are glad that you're in Taylorsville helping folks as best you can. So the next person we're going to hear from is there, as you heard from Jason, there is definitely an economic development and economic impact of the concept of closing the coverage gap. And it's now my pleasure to introduce Jen Bosser. She is the president and CEO of the Iredell Economic Development Corporation. And she's going to talk a little bit about what could happen with business and how that could help business if we were to close the coverage gap. So Jen, please talk to us about business in Iredell County and in the upper central line of Piedmont.
Thank you. Can you hear me okay?
Yes, ma'am.
Okay, great. You can skip this slide, go on to the next one. So yes, well, I guess I should have introduced, so you introduced me, Jen Boser. I'm president and CEO of Iredell County Economic Development. We represent the 14th largest county in North Carolina. We have a population of 180,000 people, and I'm going to talk a little bit about Peg, the impact of COVID, and also the economic impact that we're seeing. So first, I kind of want to give you a little bit of perspective on Iredell County. We have a pretty large county, as I mentioned, and about almost 15% of Iredell's adult population is uninsured. It sounds small, but it actually translates to about 14,000 people. So when you hear it as not a percentage, but actually as a number, I think that starts to give you a little bit more reality around that. You can go to the next slide, please. So the medium household income and the medium family income in Iredell are the numbers that you see there. We have about 10.6% of the population that falls below the poverty line. I think what's important here is that that household income has grown by across the county about 23% since 2000, but it's not evenly distributed across the county. Iredell is very diverse. We have mostly agriculture in the north, manufacturing, distribution, and warehousing in the middle and the south, and then a very affluent community in Mooresville with emerging growth in healthcare, financial services, high tech, and defense and aerospace. So Mooresville's seeing the strongest growth because of its proximity to Charlotte and having real estate for housing along the shores of Lake Norman. But I think it's important to point out that while that's the average household income for the county, it may not be the same in areas north of the county. So you can go to the next slide. So what I wanted to show too is it's not just about Iredell County. We actually are very dependent on the counties around us, and we're one of the very few counties in North Carolina that's actually surrounded by other counties. So we actually have 9 counties total around us, and those are listed there. The population in 2000 was 121,000 people, and we've seen an increase of approximately 60,000 people over the last 20 years which is about a 33% population growth. That's pretty significant for the last 2 decades. In the last decade, that slowed some to about 11% since 2010. But we pull from our neighboring counties for our labor force. And I won't go into all the stats for our neighboring counties, but I want to just point out the population growth. You'll see here that that we have sort of a range of population growth across the counties. North Carolina receives 194 newcomers a day from all places of the country. We're actually the 3rd most popular migration state in the US, behind Florida and California. And we saw a net growth of 3 million people since the year 2000. Newcomers bring a migration dividend, arriving with more per capita income and adding purchasing power. But again, it's not evenly distributed. So there are 100 counties in North Carolina, 42% of those 194 newcomers moved into Wake and Mecklenburg County. 75% were in 10 counties of the 100, and 95% were in 23 counties. Iredell placed 14th fastest growing among those counties. But the significance of this is that 42 counties lost population. 22 counties had more deaths exceed births, and with more out-migration than in-migration. And you can see that's even happening in neighboring counties around Iredell. So our success is not only dependent on the success of what happens in Iredell, it's dependent on the success of what happens in our region and in our state, to Jason's point earlier. Next slide, please. So, you know, it's the significance of this is really where it hits businesses that are smaller. So 70.4% of Iredell County's businesses have 20 or fewer employees. And most of these businesses can't afford healthcare insurance for their employees. These employees fall within the gap of qualifying for Medicare and paying health insurance on their own because their employer does not cover them. As a small business, I'll speak for my organization. We have 6 employees, and our healthcare expenses account for 13% of our total budget. And that's a huge expense for a nonprofit, but also for a small business when you think about that's a reoccurring expense and not something that you can cut. Next slide, please. So in terms of Iredell County, I think it's important to look at our employment distribution. Manufacturing is the largest in Iredell County, followed by retail, healthcare, accommodation and food services, education services, and construction. The total, so when you look at this and you look at the familiesusa.org report, you'll see that these industry sectors are the most vulnerable to having employees fall within that healthcare gap. Manufacturing is to some degree. It depends on the nature of that facility. But this represents about 58%, those in blue, 58% of Iredell's industry employment distribution. Add manufacturing, and that's 78%. Go to the next slide, please. So the impacts are really when you lose jobs, you have business closures, and you lose buying power. And you're going to see, or we are seeing, negative impacts on the sales tax base. We had companies who had to, close under the state of emergency and governor executive orders. We're starting to open some of those back up. Some businesses are not going to reopen. We've seen a huge shift in e-commerce, which means that people who traditionally would go to their retail store are now afraid to, and even The senior generation is starting to use e-commerce, which I think once they've learned that technology, and with the scare of being out and getting COVID, they're going to continue that that behavior. Tourism continues to suffer and probably will for some time. We've had some slower collections on property taxes, and that creates budget restraints on our municipal governments. I think the question is still out on how big of an impact that's going to be, because businesses have been able to take advantage of financing programs like PPE and others. And municipalities have faced a loss in utility revenue, and some have actually not been able to collect late fees, which traditionally has been a revenue source as well. And next slide, please. So I wanted to share something that came out last Tuesday, because I found that this was really compelling. And if you have a chance, WRAL actually has, it's through WRAL TechWire, they actually have a video that you can watch of this presentation. But it was really the 7 forces shaping the economy and what's going to happen next and what we can expect. And so, as Jason mentioned earlier today, that the economy appears to be stuck. And we saw a downturn in March and April. Since June, we've been stuck. Growth is stalling, especially with small businesses. The most obvious shift is towards on-demand and online retailing, which will really change the way our small retailers function. And certain segments of the market are seeing an explosive demand, like grocery and home improvement, but others are not. And this has taken the biggest hit on hospitality, retail, restaurants, hotels, and it has a trickle effect on supply chains and our labor force. So lower income people of color, females with children have been the most impacted. And they tend to be our workers in retail, goods and services, sports, entertainment, and in other areas. So we've been somewhat shielded from the full brunt because of federal stimulus, and that has supported our small businesses, but that's about to run out. So unemployment peaked in the spring with close to a 15% unemployment rate. If you add furloughed workers, you will see that it's closer to 20%. And there's an expected next wave to hit on middle income families. White collar furloughs are expected to be coming in the coming months. A few banks have noted that they plan layoffs, and household debt has increased by 30%, putting us in a bad position. So we're probably going to see more impacts happen. The healthcare sector has been significantly impacted, and we should. I think they've lost. June exceeded. Between March and June, they exceeded almost $200 billion in losses, and that's not recoverable. Hospitals that traditionally saw a 10% profile on their margins would reinvest that capital into improvements and medical equipment, and they're not going to be able to do that, and they're going to have to catch up for some time. In addition, small rural hospitals are closing at an alarming rate, which just further sets back those counties that are already set back further. And we're seeing a migration of people leaving places like New York, San Francisco, and Chicago. And fortunately for North Carolina, we're a magnet. The Southeast is a magnet, so that's a positive. But as I mentioned before, that prosperity will not be evenly distributed. You're going to see more growth in suburban and urban areas, but there's going to be more competition as well for the jobs that do exist. Next slide, please. I'm sorry, I'm keeping up with my notes. All right, I can't get my, there we go. I have the screen behind me. So, So if we expanded Medicare and Medicaid expansion in Iredell County, we would have 9,720 residents be able to access affordable health care. That's an impact of 568 new jobs and 122 million in new business activities, which would also result in 1.74 million in new revenues. So this is a really good impact for us, and especially now with COVID, I think something that we need. Next slide, please. So my final takeaways are the hardest hit industries are the ones that employ the lowest paid workers. The funding that the federal government has held back, which is 2 years of funding, and Meg, you can give the stat for them on that, the amount that could aid in the recovery to help close the gap when employees need it the most coming out of this pandemic. North Carolina is one of 12 states that's not expanded Medicare, and this could present challenges for business recruitment when companies evaluate the cost of doing business. So those are my thoughts.
And thank you very, very much. And we all appreciate the thoughtfulness with which you made your presentation and the research you did in order to really make this concrete. There is a compelling business reason that we should move forward. And we don't want to be that last part of the dirty dozen. We need to put North Carolina in the yes column. So now our next guest is Nancy Litton. And Haley, I will ask you to take Nancy off mute so she can make her presentation. Nancy is the Executive Director of the Community Free Clinic of Cabarrus County. So Nancy's going to talk about the safety net and what she's seeing as far as the uninsured, the impact of COVID, and what it's doing to the free clinic in Cabarrus and what's generally happening on the ground in Cabarrus County.
Thank you. Thank you. I appreciate this opportunity to join our panelists and speak with our audience. I'm joining you from the wonderful city of Concord, North Carolina, the heart of Cabarrus County. So I really would like to speak about the uninsured, about those men and women who make up those numbers and those statistics. I'd like to share with you a bit about the safety net system and how we function across North Carolina, and maybe even bring to you some resources you may have previously been unaware of that might be beneficial for your constituents and your residents in your hometown. So I'd like to start maybe by saying that for the free clinic in Cabarrus County, the expansion of Medicaid, Medicare really might not have a real bearing on our target audience or our patients and population, because we've always been designed to really address those who are not insured and would not really have the ability to be insured, if you will. But I really would like for you to take away today the notion or the understanding that as a free clinic entity, the benefit to my population, the benefit to my community, the ability for my clinic to succeed and advance will be very much impacted in the opportunity for expanding Medicaid and Medicare across the state. I like to think of that phrase that's often used, that a rising tide lifts all ships. It's not going to eliminate the need for the community free clinic, but it's certainly going to make healthcare and the foundation of healthcare better in my community. So I'm really hopeful. I'm really wanting to express my encouragement that we move in that direction. So I also intend to just really talk with you. I'd love to tell you I have all kinds of great slides and maybe even some graphics that have movement and such, but you just really have my talking head. So before I get too deep into my conversation, I want to ask each of you that are listening today, I want you to reflect a moment about healthcare for you, insurance for you. your state of well-being today. I'd like for you to ponder a couple of things for me. This morning, did you by chance need to take medications for conditions or problems that you're struggling with, or that you're maintaining, that your well-being and your health is much to the credit of having medications that removes some of those complications of a condition like hypertension or diabetes? So I want you to think a little bit about that for me, because I want you to think about how you went about doing your medications this morning. And maybe even think a little bit about, how did the medications get to your home? How did you have that ease of confidence this morning as you stumbled out of bed and made your way to the bathroom, to your medicine cabinet or your vanity or wherever? What was your ease of confidence of knowing that medication was going to be there? And you can expect it to be there tomorrow. When the bottle runs empty, you can expect to be able to replace it. I'd like for you to think about that, because in the safety net community, it's those unassurances, it's those complications, it's the things that we don't take for granted that are a part of the fixes that we have to address, or the ways we have to address ourselves to help with fixing things for folks. A little bit later, I'm going to pose another opportunity for you to think a little bit, but let's just stay with the medications, if you will. And I'd like you to know that the Community Free Clinic is now over 25 years old. And when we began back in 1994, it really was around chronic conditions and many of our working poor who weren't getting those chronic conditions addressed well enough. And I love when Mr. Katz talks about how people are proud. They're really not looking for charity. They want to be able to take care of things themselves. So we would often in this community see people trying to deal with health issues in the emergency department, in the emergency room. So locally in Cabarrus County, the physician population, the network of men and women who were primary care providers, who were internists or what have you, they gathered around a table and determined that as a community we could address this if we just all show up and do a little bit of that work for this particular population. And we do it in that framework of primary care, or that framework of a routine visit, as opposed to doing it from the emergency department. So let's do this with people in a way that keeps them with their conditions controlled, instead of allowing them to become in crisis and then dealing with a crisis. So a clinic was established, and a routine, a rotation was set up, and a couple of evenings each week, physicians and all of their support staff, their nurses, their administrators, their registrars, whomever, they showed up at the clinic and they manned the clinic. And it was a partnership. That structure is really how we addressed the uninsured 25 years ago. And the clinic still exists. We're still addressing those uninsured individuals. But it's a little different dynamic now than it was 25 years ago. So I'm going to share with you, if you will, just who gets help from a free clinic, who is benefiting from the safety net structure for healthcare. In Cabarrus County, patients that see us at the Community Free Clinic are at 125% of poverty or below. And that's really on the low side. I think across the state of North Carolina, you would find free clinics or charitable clinics, or even the federally qualified health centers. I think you would see them seeing patients at well above 125% of poverty, really more like 200% of poverty. So in Cabarrus County, what I'd like you to know is we do have a safety net. We do have a federally qualified health center. So for the Community Free Clinic to be at that lowest end of income is manageable, because we have that next tier of available care. But just to put it in perspective, the individual, the single adult person who works in one of these retail stores or hospitality avenues that we've been talking about, that individual who makes minimum wage, should that person actually work 40 hours a week, should they have the ability to work 52 weeks out of the year, they would be just slightly over income of 125% of poverty. They could technically not qualify for free care at community free clinic because they're over income. So when we talk about our population, we're talking about folks that are way below minimum wage. As a matter of fact, 80% of my patients are actually below 100% of poverty. The other thing I want you to know about my patient population is they really are falling between Medicare and Medicaid. We're talking about people who are 18 years of age up to 64 years of age. Once an individual bridges 64, we anticipate the Medicare availability and they move into that program. If you're under 18, we expect that you're going to be covered by Medicaid, and therefore we're not covering that population. So one of the things, though, that's really remarkable is that many times people expect the adult population to be covered by the Affordable Care Act. And they really don't understand, why would a free clinic be needed? I mean, there's all this available insurance for folks, and they can just buy a premium and be seen in the private healthcare market. Well, the truth of the matter is, in North Carolina, if you happen to be low income and you do enter into the marketplace and you plug in your income, in North Carolina, because we didn't expand Medicaid, many people find they're denied the marketplace insurance because they are expected to be eligible for Medicaid. And when they're expected to be eligible for Medicaid, then they're excluded from marketplace insurance. And that's a part of the population that we're seeing here at Cabarrus County's Community Free Clinic. So I want to help you with understanding that as well. One of the things we know in Cabarrus County is that the uninsured numbers were beginning to drop. We were seeing improvement. The economic improvement over the course of many years was beginning to bring us more individuals who did in fact have insurance, but COVID's made a big change in that. So now we're looking again at having to look at increasing numbers of individuals who are without insurance. So I'd also like to share with you that the scenario that we are hopeful of, or that we have maybe been able to see these last 6 to 8 months, is we've been able to see a physician, a practice group, who would continue to see a patient even though they lost their insurance, because they weren't trying immediately to just disqualify a patient from their care simply because they'd lost insurance. And maybe we were seeing individuals who hadn't actually needed to access health care because they weren't at that 6-month appointment due for renewing their prescription, or maybe they just didn't yet have a reason to have to see the doctor. But over the last several weeks and several months, we have been seeing an increase in applications for health care through our free clinic services. We refer to our healthcare program as the pink card because it's historically been managed with a card that was literally pink. So we continue to refer to it as the pink card program. Our physicians in this community are willing to take a certain portion of all of these pink card patients to help spread the patient population in that same spirit of how the free clinic was developed originally, in partnership with the private medical community. But a big part of what we are managing with our uninsured, with our individuals with chronic conditions, is their pharmacy care. And pharmacy care is a significant burden, if you will. And I say burden simply because so many chronic conditions aren't managed without pharmacy supplies and pharmacy products. And that's important for us to have. So the clinic here in Cabarrus County does have a pharmacy as well as our clinical care. And we work in partnership with North Carolina Medicist, and some of those medication assistance programs are already spoken about. But you know, it's difficult sometimes to make sure we get everything turned in and collected correctly. I ask you at the onset to think a little bit about how you could be assured that your pharmacy products would be in your bathroom, at your vanity. I'd like to wonder how many of us today had to deal with our tax returns before we were able to contemplate our healthcare coverage, and our pharmacy resources. Because our patients, as they apply for the programs that are available to them, part of that program application involves things like your last income tax return. And how do you keep up with that? And when would you have that available? And that's a complication, if you will, that we often see in doing healthcare and pharmacy care on a charity or a safety net platform as we do. And expanding Medicare and Medicaid would help remove some of those burdens as well. So as we, and I'm looking quickly at my clock and appreciating my time, I want you all to think a little bit about the people that are a part of who receive care outside of the normal venue or what method that you may do. Those folks who haven't had the continuity of private insurance for all of their lives. I'd like you to think also about the fact that it's very possible that those individuals are balancing more than just simply not having insurance. The Community Free Clinic evaluates the determinants of health that our patients are also dealing with. And in the last 2 years, we've been able to identify food insecurity, economic issues, housing issues, as we might expect, but also just social isolation as being contributors or factors that need to be balanced as we're giving care to individuals. So at the Community Free Clinic, we are seeing people for your basic clinical needs. Let me check your blood pressure. Let me weigh you. But we're also inquiring, tell me about your living circumstances. Tell me about how stable your housing is. Have you been able to eat this week? Have you been able to be sure that you will have food for the next week or the next month? Those sorts of things as well. We use programs such as our lifestyle medicine program to help bring patients into both their care plan, but also a community environment of dealing with lifestyle issues such that they can have more engagement and involvement in their personal health and their personal well-being, allowing them the opportunity to be able to, if you will, engage and have an active role in their health as well as the patients and their fellow patients that are being seen here at the Community Free Clinic. So I probably would love to talk forever and ever. I'm going to leave you with one last thing. One of our big issues with COVID is that everything seems to be going remote. Telehealth, education and training through Zoom, through interactive online venues. And many of our patients don't have stable Wi-Fi and aren't able to engage the same way that you and I do. So I'll also ask you to think, the last time you had to have a physician interaction, did you do it by your computer? Was it through telehealth? And did you have any interruptions or issues with being able to do that readily and availably? Because many times it's still a barrier for our patients to see us, even in this wonderful world of electronic or computer-based interaction as well. So I'm not watching the clock right this minute, but I'm sure I'm near my time. So thank you for letting me be with you. Thank you for letting me present a little bit about the patients and the healthcare safety net as it exists in North Carolina.
Nancy, thank you very much, and thank you so much for the work that you're doing in Cabarrus County. Our friend Randy Jordan said you were a rock star, and he was absolutely right. So the next presenter we have is Erica Palmer-Smith, who is the Director of Care for Carolina, and she's going to talk about some policy opportunities. And it's funny, Nancy, as you were saying about internet stability, that little thing on my computer started going down and freaking me out. So hopefully we'll all stay connected. Erica, take it away.
Thank you. And first, I'll just say I'm excited to be a part of this particular group today. As Peg mentioned before, Taylorsville is my hometown, so it's wonderful to be on here with Jeffrey Katz and many of you. So thank you for joining us today. Haley, next slide, please. So in North Carolina right now, we have a tremendous policy opportunity. We have an opportunity to expand quality, affordable coverage to nearly post-COVID 750,000 North Carolinians. We have an opportunity to ensure that all of our frontline workers have access to timely testing and treatment for COVID-19. We have an opportunity to help stabilize the healthcare system by reducing the amount of uncompensated care costs. And we have an opportunity to provide a lifeline to struggling families. And we can do all of this with 90% of the funding coming from the federal government, from tax dollars that we already pay in. There has been multiple pieces of proposed legislation that would address this. The most significant that moved the furthest was House Bill 655, North Carolina Healthcare for Working Families. This was a bipartisan piece of legislation that passed out of the House Health Committee 25-6. It was promised a vote on the floor by leadership, but that vote never came. We've also seen recently House Bill 1040, Healthcare for Working North Carolinians, which would expand Medicaid in North Carolina. And we've seen House Bill 1103, Access to Affordable Health Coverage for All, which would provide subsidies for folks in the coverage gap. Before I move on, I want to quickly say thank you to Representative Fraley, who represents Iredell County, for his co-sponsorship of House Bill 655. He was a wonderful champion, and we appreciate him very much. But again, there are three pieces of legislation here. There have been others in the past that have been put forward, and what we have seen is a failure to actually take a vote on the House or Senate floor to move something along. We know right now that there are far more North Carolinians suffering than there have been at any point in the past. And pre-COVID, we had close to 500,000 who needed this coverage. So what we know is that now is the time to act. And we also know, next slide please, Haley, that North Carolina voters agree. We funded a poll through the D. Stewart group, the conservative D. Stewart group, along with Harper Polling at the end of August of this year, looking at voter opinion around closing the coverage gap. And what we found, Haley, next slide please, is that 75%, 3 in 4 North Carolina voters support closing the coverage gap. That's compared to only 16% who oppose. Next slide, please. And we found that this held up across every key demographic. So partisanship, this is not a partisan issue. 64% of Republicans, 83% of Democrats, and 76% of unaffiliated voters supported closing the gap. Whether someone identified as very conservative all the way to liberal, they supported closing the gap. When we looked across age, when we looked across gender, when we looked across race, and even media markets across our state, the different regions, we found that these numbers held up. A vast majority of North Carolina voters support closing the gap. A couple things that we know did play a role in this. We know that 78% of voters believe that the impacts of COVID-19 will be long lasting, for good reason, as you've seen pointed out. But what I thought was so incredibly significant was that 1/3 of North Carolina voters are concerned now about their own family's access to healthcare. So imagine that 1/3 of our family and friends and neighbors are worried about how they're going to afford healthcare in the future right now, post-COVID. Next slide, please. Thank you, Haley.
All right. So, we've talked about how this issue of the coverage gap impacts individuals. Jen did a brilliant job of laying out the impact it's having on businesses and people in Iredell County, and Jason talked about what's going on statewide. So in order to address the economic impact and how closing the gap can help us, Care for Carolina has created the Business Advisory Council. And one of our stars of the Business Council is Miles Atkins from Iredell Health System. And so Miles, I'm going to ask you just to take us through a few minutes of what's going on with the Business Council and what you hope to accomplish.
Thanks, Peg. I'm happy to do so. And again, just want to thank all of our panelists today because this really helps tie everything together. So the Business Council, the purpose is really to raise awareness among the business community of the economic and business benefits of closing the health insurance gap and making the business case. Next slide, Haley. So the council just launched in September 23rd. It's a bipartisan group of business and community leaders that I'm proud to be a part of. It's a group that is interested in the healthy and economically strong North Carolina. And some of the members that are included is the chair. The chair of the group is the council is Patrick Woody, president of the North Carolina Rural Center. Former Secretary of State Sharon Decker also serves. President of Leadership North Carolina is Brian Etheridge serving. Incoming president of the North Carolina Medical Society, Dr. Phil Brown, is on the council. We have numerous county commissioners and economic developer leaders from both east and west parts of the state. And the president of North Carolina Healthcare Association, Steve Lawrence, is also serving on the council. So, what you've been hearing a lot from everybody is really there is a business case to be made for closing the insurance gap. Next slide, Haley. And so I want to talk a little bit about that. And next slide, Haley. And so we've really broken it up into about 6 pillars to think about how do we build this business case and for success. And as we heard from Jason Gray, the gross revenues and tax revenues that will flow into our communities and the new jobs are greater than any other policy that our state can take forward. And so we're going to walk through the 6 pillars. Next slide, Haley. Thank you. So the first 3, we're talking about strengthening local economies by creating much needed new business activity, jobs, and tax revenue. We want to support rural hospitals and local healthcare providers by reducing uncompensated care. Additionally, we want to stabilize healthcare premiums by reducing cost shifting for care from uninsured to the insured and private pay patients. Next slide. Also want to reinforce industries and small businesses that cannot afford to provide health insurance to their employees, which you've heard there's several business sectors that just can't really do that. We want to protect the frontline workers, many who work in businesses that cannot provide health insurance. And finally, we want to accelerate. We want to accelerate the creation of small businesses by providing new entrepreneurs with an affordable health insurance option. So as you know, many of our workforce sectors cannot offer health insurance to their employees, either because of their size, their structure, and business model of their work. This will help the workers and the businesses that cannot afford to offer a group health plan to their employees. This is a restaurant, childcare, nursing home, farming, firefighters, construction, and almost all services and retail jobs. Now, the pandemic has made this even more clear, with most of our frontline workers that we are relying on not being covered. 80% of nursing home workers are not insured. Next slide, please. So as you'll see, we've gained tremendous support across the state for closing the healthcare insurance gap with our business and community leaders. As you can see, since this slide was made, we've actually increased up to 184 supporters that are shown. We have support in over 54 counties to date and are actively reaching out across the state to identify at least 3 business and community organizations in all 100 counties. Next slide, please. So as you can see, the business leader support list is organized into 3 regions: the Central, Western, and Eastern. The region of the state is in the Central section. As you can see listed, there are 65 business leaders and business owners and chambers who have signed support, and we are just getting started. As a member of the council, I've agreed to share this information and business and community leaders and introduce them to this issue and how it is affecting our community. For those that are supporting closing the gap, I'm asking them to add their names to make their support visible. Next slide, Haley, thank you. And this also includes inviting civic leaders to show their support in a fairly new area for us. As mayor, I see this as a big opportunity for many local leaders to share the benefits of this policy for their community. You can see my name there, and I invite you to join me. And I know you're dying just asking, how can I do that? I tell that to you. Next slide, Haley. So all you have to do is really go to the Care for Carolina website, visit Act Now page, the Act Now page, and select Sign as a Business Leader. And as you sign as a business leader, which also where civic leaders can sign right now, as a North Carolina business and civic leader, it says, I endorse the following statement. And then also, if you put your title as mayor or economic development board member, we'll put you on the civic list. This is for a small business owner just as much as a chamber leader or a larger company. And finally, next slide, Haley. And finally, you know, if you're part of a body that has a formal resolution process, like a chamber board, a commissioner, council, or economic development board, let me or Dr. Meg Malloy know. We can get you information to take a resolution to your board. Thanks, keeping track of all the signed resolutions and adding those organizations to the growing list of supporters. I'm excited about this opportunity, and I invite you to join me to close the North Carolina health insurance gap. And thank you, and I look forward to any questions for our Q&A at this time.
Very good. Thank you, Miles. Miles, you really are a true leader. And I have seen that slide, that last slide that was there from the Pitt County Commissioners, and I just realized it was my cousin Beth, who was the county chair of the Chamber of the County Commissioners, and I just saw her name, so I'll have to send her a note and say, thank you, you are becoming statewide famous. So now we've got time to open things up for questions from the folks on the chat. And so again, there's a couple ways you can go here. You can go to, good heavens, I just lost my Zoom. You can go to the bottom of your screen, and where it says participants, you can click on that, and that will bring everybody up on the side. And then you can, or you can type something in the chat box. So I'm going to hit that bar and see if I've got any raised hands over here. But while we're waiting for people, for the technology to improve and for Haley to take folks who want to raise their hand off the mic, I will ask a question that seems to have been a thread that's, Miles, you talked about it, Jen, you spoke about it, and I think, Jason, you alluded to it, is this issue of cost shifting. And Miles, you work for a health system, so you know firsthand what the uncompensated care does to your ability to treat people, but also how much it shifts over to the people who are actually privately insured. Will expanding the pool of insured by closing the coverage gap, will that have an impact on private insurance rates?
Peg, if you're asking me, absolutely it will. You know, we will not turn anyone away for care, and so we're going to absorb those. We're going to absorb those costs, and eventually it becomes part of a charity care that we're giving back to the community. But it has a tremendous financial impact on us, and quite frankly, there's people that won't seek care because they don't have coverage and they're afraid to come in because they don't know that they can actually as a nonprofit healthcare system that we're going to see them and we're going to turn them away. But it definitely would have a tremendous impact. And it does, as you stated, it does shift the cost of care to those that do have insurance. It does increase, and it does have a direct impact on what they're paying as well. Very good.
Others on the panel want to address that? Jen, I think I should have known this, but when you said for your business, 13% of your fixed cost are your health insurance costs. That is amazing. Mm-hmm. And that there's nothing you can do about that. Mm-hmm. I mean, other than not offer insurance.
Yeah, that's right. And, you know, and then what companies have to face is the ability to compete for talent. And so, you know, offering healthcare is just one of those things that you have to do to compete for talent. So, yeah.
You've talked about in the past about having an insured population is an issue of competitiveness as we compete with not just one county versus another, but from state to state, and that how, because of Virginia's actions, that they could be soon snapping up people, small businesses or larger businesses from North Carolina, having it be an issue of interstate competitiveness.
I missed the first part of your comment, Peg.
Just Jason has talked about the competition between states for those who have expanded some kind of coverage gap solution and those who have not. And I see Haley Jason's microphone is muted. If Jason, if you want to take a shot at that.
Yes, just very quickly. I mean, we are in a competitive environment around everything. For example, in 2011, 2012, North Carolina's corporate income tax was substantially higher than it was in surrounding states in the region. And the General Assembly made the decision to cut the corporate income tax to be level with surrounding states, and then they actually cut it even below the other states. And the rationale behind that was that it's going to make us more competitive. We are in a highly competitive environment with other states competing with other countries, and quality of life issues, again, housing, our healthcare networks, the health of our workforce and of our population is the defining issues that sets the competitiveness of one state or one community against another. So as my presentation suggested, closing the coverage gap is a huge deal for those who would benefit from that, but it has far broader economic implications. And in the competitive environment we're in, we have to be mindful of that as being only one of 11 or 12 states now that do not have this benefit. So I mean, this is just the world we work in.
Very good. Thank you, Jason. So not to be defeated by technology, we've had someone who's listening, Bruce Hoof, couldn't raise his hand and can't chat, but he has emailed Erica, who has emailed me. So again, we will never, ever give up. So Bruce Hoof says, why haven't any of these bills been given a vote in the legislature? It seems like this should be supported on a nonpartisan basis. Assuming there is opposition to Medicaid expansion, what is the argument of the opposition? Erica, you want to take a shot at that?
Sure. So there are a couple of arguments that we hear predominantly when this comes up. I will share both of those with you, and I will also share with you why they don't really hold water when you look at the details behind them. So the arguments really come down to cost and who it is that we're covering. So I'll address cost first. There are concerns about how we pay for this. So first of all, 90% comes from the federal government, and the proposals that have been put forward, such as 655, would have cost $0 to North Carolina taxpayers. The argument is that the 90% could go away. The problem with that is that argument ignores what the legislation actually says. So in the Affordable Care Act, it states that the federal government will cover 90% of the costs in perpetuity. There is no wiggle room for that 90% to get dropped down without a change in legislation. So there have been comparisons to where the Children's Health Insurance Program, for example, has temporarily been raised and then lowered. This is a different program with completely different legislation. In order for the 90% number to drop in any way, Congress would have to pass new legislation to change that, and the president would then have to sign new legislation that Congress passed. So ultimately, we would have to change the Affordable Care Act. That does not appear to be a very real risk at this time, that Congress will go in and pass entirely new legislation to alter that 90%. Again, this is not something that, as it has been depicted, could just willy-nilly be changed on a whim. Secondly to that, as many of our presenters mentioned earlier, 38 states and the District of Columbia have all passed some form of Medicaid expansion or closed their coverage gap. And we would have to see legislators from 38 states basically mess up what their states are doing in terms of covering their people. And so just the political risks of that seem quite slim. Secondly, we hear concerns about who we're covering, and what you have likely heard is this phrase, able-bodied childless adults who don't work. That could not be further from the truth. 63% of those in the gap are working. On top of that, about a quarter, pre-COVID, 120,000 parents in North Carolina are living in the coverage gap. So I want to give you an example of what that can look like. So let's say that we have a single mom who has one child. For her to qualify for Medicaid, she would need to make less than 43% of the federal poverty line. For a family of two, that's around $7,200. Let's say she works. I think Nancy gave an example earlier of someone who's working full-time, making minimum wage. Let's say she can work 52 weeks a year. She's not making nearly enough to get a subsidy in the private insurance marketplace. So this single mom who's working full-time, if her employer can't offer her insurance, like 70% of the employers in Iredell County, for example, she has no way to get insurance coverage. So what we know is that the folks who are living in the gap are predominantly our farmers, they are our retail workers, our grocery clerks, our childcare workers, our nursing home workers. These are people who we depend on every day. These are our essential workers. They are not able-bodied childless adults who choose to sit at home. These are people trying to make a living and put food on the table.
Thank you. And I think Jeffrey Katz referred to that same issue, that these are not people who are looking for a handout. They are actually, all they want to do is be healthy so they can support their family. But Jeffrey, I will ask you, and I know you work for a larger health system, but one of the things that we have heard from other practitioners around the state is the economic hit that physician assistant offices, NP offices, doctor's offices had during COVID, because people weren't able to come in. Have you seen that in your community, where actual, we have this vision of doctors always being wealthy, and but in many ways, physician practices are small businesses. Your practice is a small business connected to a larger business. How are our practitioners faring economically as we sort of claw our way out of this?
So initially, we probably saw in March and April, our visits down almost 50%. People were afraid to come, although it always struck us as interesting that they would go to Walmart but not come here. We think that we kind of clean a little better. However, as time has gone on, that has rebounded some, especially for the family medicine practices and also for specialty practices, because for a while, hospitals were not doing elective surgeries. So many of the folks who I'm in contact with, not only in North Carolina, but around the country, especially some of the PAs who worked in specialty practices, they were furloughed for periods of time. That is slowly coming back, although I'll tell you the perception from some folks about being concerned about coming into a medical office here is still there. And we still are seeing people who are not coming in for their chronic disease follow-up. And we're also seeing people who are sick who are waiting to come in. Oh, I'll see if I get a little sicker, as opposed to kind of coming in a little bit earlier. So it still is hitting us some, but nowhere near as what it was in the springtime.
Thank you. And Nancy, I'll ask you, Haley, if you can take Nancy off mute. What are you seeing with your patients? Did you see a drop in the folks coming in, or did you actually experience an increase in volume as people were experiencing the what was going on with COVID?
We've been fortunate in being able to stay connected with our patients doing telehealth, maybe leaning more on the phone version of telehealth than the computer. But at the same time, we were really very insistent on trying to keep our patients at home. I think something that would be helpful for the audience to know is a real benefit of the safety net programs is they do help keep people healthy. So our population is very much the middle of that high risk population. Many extenuating circumstances that put them at risk, along with their health issues, maybe some weight issues and such. But because we are very connected with our patients, helping them maintain their blood pressure, maintain their diabetes, keep it in a status of being better controlled versus out of control, keeping them in the supplies of their medication has helped them with being able to be maybe a little bit more able to avoid some of the risk that might add to their chances of exposure. Similarly, we really tried to keep people home. You know, we began sending medications by the mail as opposed to having people come in. We're very much an in-house operations pre-COVID. So what I would want you to know is that we've been really very pleased with the proportion of our individual patients that have had a risk of exposure, who've been concerned about exposure, or who may actually have become exposed and be ill. We've been very pleased with that, but we have at the same time had the phone calls, received the outreach to say, now that I don't have coverage, can I come to you for a healthcare issue and such? Is that helpful?
That is very much. And we have one question in the chat box from Marion Little about reaching out to people who may be eligible for the Affordable Care Act. I think that's what you're asking, Marion. I have we're running out of time now, but I have a couple of suggestions of folks who might give you some suggestions on good outreach techniques for what you're trying to do. So if you're agreeable, Marion, and I'm looking for your face here, if you're agreeable with that, I will be in touch offline and send you a couple of contacts that might be helpful. Very good. Well, I think we are in, Meg is just thanking everyone. I was just about to do that. Thanks to each of you for giving your time. Our panelists, Jeffrey, you were amazing. Jason, you are always amazing. Miles, I know you have a city to run and a hospital to organize, so thank you very much. And Nancy, I know you're taking time away from patients. So, and Jen, again, the thoughtful way you approached the question of the economic benefits and the economic hit that's happened in Iredell is just amazing. And Jason, I'm going to make sure that you look at Jen's numbers because they are as good as yours, but on a one county level. They're very, very thoughtful. I want to make sure you check them out.
They're even better. I'm sure they're even better, and I look forward to seeing them.
Very good. So you all, Erica will be in touch, or Haley, or all Erica and Haley, with some follow-up information, your county data, so that you'll know what closing the coverage gap could do for your specific county. If you want resolutions, if you want ideas about writing letters to legislators, writing letters to the editor, we are here to help you with all of that. And so Erica will be in touch, and please let us do what we can to help you reach out so that come January, when our General Assembly comes back into session, they will know that the people of what we have made up called Centralina, but the people of the Upper Piedmont are interested in this issue and they want action. So I think unless anybody's got something to say in 1 minute, I think we can close the meeting. And again, for all of you who attended, thank you so much for your time. And for many of you, I've known your names, and now I'm glad to get to see your faces. So be well, everybody, and thank you for everything. Take care.